Good morning, everyone. If you could please take your seats so we could get started. The General. Folks, once again, I want to say good morning to you. We're going to start out with, quite frankly, with an exciting session. And to start things off, I want to introduce my good friend and colleague and the immediate past president who's still here working. So I certainly appreciate that. I want to introduce Paul Conway. Paul has been dealing with kidney disease for 37 years. He started out when he was about 8. But, you know, I do want to say that, you know, we always look at folks. Like I say, it's going to be a lively session. But the thing that I want to impart to you, because we always, you know, we have patient advocates, but the reality is that Paul has the experience of somebody many years older. Paul has worked for 4 presidents, 3 governors. He's a veteran of over 100 political campaigns, and on many occasions, he is one of the talking heads. He's a news contributor to the Fox business station on talking about employment and jobs. So many of the strategies that we have used to grow as an organization are concepts that he's come up with and applied to us as a grassroots organization, which has allowed us to grow the way that we have. So, without further ado, I want to welcome Paul Conway to the mic to moderate the session.
Richard Knight. Well, good morning, everybody. This morning's session is called Under the Dome. And so I don't know if people know this or not, but Richard Knight is a veteran of Capitol Hill and a very good friend. We've been doing this together at the American Association of Kidney Patients now for about 10 years. We are like Velcro. We're good friends. We like to kid around a lot. But most importantly, we try to use our experiences from government and from politics to advance the patient interest. And we have a lot of folks here of different political persuasions, but the most important thing, and you'll see this as I go through some slides, is what matters is the central focus on patients and patient voice, and then gain every skill that you have and every experience and apply that to that. Kidney disease is a funny thing in many ways. Partisanship actually doesn't matter in it. And the opportunities that you can realize if you work together are limitless. You just have to look at the big picture. But Richard's been at this for a long time. I'd also like to recognize one of our newer board members, Ed Hickey, who's also a veteran of Capitol Hill. He heads up our Veterans Health Initiative. And as you will hear later tomorrow, for Representative Silvio Conte in the late 1980s and early 1990s, Ed was the architect for the congressman of the decade of the brain. And we'll be talking about that because we're about to launch into the decade of the kidney. But our point here is this morning, as we go into Under the Dome, that unlike some organizations, AAKP has a tremendous amount of in-house talent, which means that we don't have to rely on out-house talent to get our legislative work done. And you can take that as you like on a Saturday morning. Richard mentioned the ability and the honor I have of contributing on television to the Fox Business Network on issues of labor and unemployment. That's the monthly unemployment numbers that are issued by the federal government. I'm a former chief of staff of the U.S. Department of Labor, and I will tell you this, that right now we're on a historic point. We're close to having one of the most historic low points of unemployment for people with disabilities in the United States because of the economy. That's a good thing. And why does that actually matter? Because the presentations that you were hearing here yesterday from folks like Bruce Culleton of CVS are all about how do you marshal innovation and technology so that patients like us can do dialysis, get transplants, and get back to work. It's a passion of mine. It's a passion of everybody that you see on the AAKP board, but most importantly, to think like an individual, to honor your aspirations and pursue opportunity, and not always have to be thinking I'm sick and I cannot work in the workforce or compete in the workforce. but that's one of the reasons why we do what we do, and a lot of it is based on innovation and the people who are presenting here who have come. Before we start the session, I'd like to mention the three great guests that we have, and then I'll do a couple of quick slides on AAKP strategy, and then we'll get into the presentations. Our first speaker that we'll have this morning is a very good friend of ours, Rob Blazer from the Renal Physicians Association. Rob heads up their government affairs operations, and literally he is a walking encyclopedia of the entire history of kidney disease policy and legislation on Capitol Hill. He is a veteran of many legislative battles. And for all of our guests who are here today, you hear a lot of disparaging things in the news sometimes about lobbyists, about hired guns, about who's representing who in Washington. There's another side to that, though, and I want to make this really clear. The professionals that are at this table, while they may not be similar to us as patients, the most important thing is this. You have a tremendous history of legislative work here at the table this morning with these guests, and they are all in terms of their commitment to advancing policies that increase patient choice and lead to better innovations and, most importantly, save lives. Rob will speak first. The second speaker that we'll have is Peggy Tai. I always butcher her name, but I got it right this morning. Better living through prednisone and coffee. Peggy is an expert with the transplant community, and she's also a partner in Powers Law Firm. She has many different titles, but her history as a legislative expert goes back more than 2 decades. We're all dating ourselves up here and getting along quite well. But she is somebody who's been involved in the mechanics of kidney availability, kidney policy, and kidney legislation as it relates to transplantation. She works very closely with the transplant surgeons in the transplant centers. Our next guest, after Peggy speaks, is Zach Cribbs, and Zach is from the American Society of Nephrology, ASN. Zach is one of the folks, as he self-describes, as the shoe leather on Capitol Hill and in other policy circles. But we have seen Zach, over the past several years, go from somebody who's at this level to ASN to a level that we would call disproportionate influence in the organization. He's the chief contact person for patients who come to Washington, D.C., who go up on Capitol Hill with AAKP and ASN. He's the guy that gets it done. He has the relationships with the congressional staff, but the most important thing you need to know about Zach is this. He always asks, is there a patient available because we have a meeting about X or Y, and I want to make certain you folks get represented. Great instinct, great talent, and you'll be seeing him for quite a long time. To start this morning, let me just go ahead and hit a couple of things. Kidney policy ecosystem. So you hear a lot of folks talk about how is policy making happening in Washington, D.C. You may feel I have no voice in the process, and it's not as simple as might be portrayed on the news at times. It's not simply something that happens on Capitol Hill. Here is a list of all of the different influences that are involved in making kidney policy in the United States. I purposely put patients and caregivers last as kind of a joke because the inverse is actually true. We are the biggest stakeholder because it's about us and what happens to us. But these are all the different organizations that we work with in order to create policy on Capitol Hill or in the executive branch. You may have seen this on social media. We're quite proud of AAKP's independent voice, and we portray that on social media, which is essentially respect my voice, never make a decision about me without me. And it's important that elected officials on both sides of the aisle, on both the Senate and the House, understand that. Our guest this morning will talk about the importance of that. And so on the news, sometimes you hear stories about lobbyists and special interests and that type of thing, and they're all like influencing Congress. But I will tell you this, an organized patient voice is more powerful than any other interest on Capitol Hill, no matter how big the check they write. The key is getting it organized and getting it articulated, and we're pretty good at that, and we're getting much better at it. Our mission, you've heard this somewhat yesterday, but let me restate it. It's fairly simple. We educate the patients on kidney disease and the implications of it, and policymakers. We advocate for policies that improve treatment, and we always defend patient choice. And what does that mean? It's far better for you to have access to the options that help you achieve your aspirations than having someone else define what you have access to or what you have the ability to use as a patient, whether that's home dialysis, preemptive transplant, in-center dialysis. That should be your choice. based on what you want to do, and that should not be decided by people who are not patients or who are not you. We feel quite strongly about that. Thank you. And the other thing that's part of our mission is you hear a lot about what people call patient engagement. You know, you have a national organization that has stood up called the PCORI, Patient-Centered Research Outcomes Institute. It's called PCORI. It's been around for about 10 years. A lot of people are out there doing academic studies on what is patient engagement, what is effective in patient engagement, that type of thing, and they're all trying to define it, and that's great. We like to think that patients can define patient engagement through direct action and through working with each other and impacting the policy that determines their outcomes. When you get right down to it, that's effective patient engagement, and you'll hear about that from our guests. How we operate, this is very important. We are nonpartisan. We are a 501c3 organization, so we are nonpartisan, and we are bipartisan in our relationships. A lot of people forget that. But it's important no matter who's in office and no matter who your representative is that you're talking to them. Republican, Democrat, independent, liberal, libertarian, whatever. It doesn't matter. What matters is you're engaged with them and talking to them. That's what we do as an organization. The other things we do, it's fairly simple. We elevate the patient voice. We protect the relationship between patients and their doctors. Again, we educate on full care choice. We defend our independence as an organization, meaning we are an independent organization. We are not owned by a corporation. We are not corporate astroturf. And we vigorously defend our letterhead. And then when we do something else that's somewhat unusual in Washington, D.C., which is this. We honor the principle of no surprises. And what does that mean? You will not find AAKP throwing the random spitball and attacking people for no reason. If we have a problem with an elected leader or a policy, you can count on it that we will be in their office on the phone talking to them directly before we ever take an action where we're saying something negative. And it grieves us when we have to do something that's negative. We usually don't do that. But we never, ever surprise a federal official with taking opposition to something without telling them in advance. We just don't operate like that. We haven't operated like that for 50 years, and we're not about to change. Other organizations in D.C. are a little bit different. They base their existence on attacking things all the time, but you won't find that with us. And our key distinctives, we're a longstanding organization. We have national credibility. We are grassroots. We're known for being credible and substantive when we are invited to the policy table, and rarely are we missing at the policy table when something's being formulated. So most recently, the executive order that was signed by President Trump, that was 18 months at least in the making. AAKP was heavily engaged. You can see the history of that on our social media pages for that which we were willing to say publicly. There was a lot that we were not going to say publicly that we kept in confidence as well. Same thing in the prior administration, President Obama and the Office of Science and Technology Policy, OSTP, we were very engaged with them when they had the White House Summit on kidney transplant or organ transplants. We were honored to be part of that. We're honored to be part of the process no matter who's in office. But the point is, we've been here for 50 years, we're going to be here for another 50 years. And that's the most important thing for the patients today and the patients that come after us. So one last point here. People ask us sometimes, how do you determine who you work with? So how is it that we've determined to work with the fine folks that we have here at the table this morning? We go through a very deliberative process, and we ask these questions. These are sometimes questions that people do not ask before they decide to associate with somebody, and then you get a lot of bad newspaper headlines. We don't operate like that. So if we determine an ally, these are the questions that we ask. Are they principled when they decide to fight for legislation? Are they experienced? Do they have results under their thing? Do they think long-term, like today's a battle, but the objective and the victory may be 3 years from now? Are they short-term emotional actors? And what does that mean? Like, do they get fired up and say something crazy on social media, and then you're not credible for the next year or two? And are they trusted? Do other people trust them? Do elected officials trust them? If they check off all that criteria, then we're probably going to do a partnership with them. But you can see on the red, the questions, if it comes back that this just doesn't make sense to do an association with them, it's usually because they're failing on one of these questions. Most importantly is, does it damage AAKP as a brand, and does it damage us as a true representative of an independent patient voice. And we try to stay away from organizations that are like that. To give you a sense, these are some of the organizations that we do have great relationships with. We go to Capitol Hill with them, we discuss political intelligence, we discuss legislative operations, and we have a very good sense that our brand will not be sullied. But this is very deliberative and it's very nuanced. We do a lot of this through our Center for Patient Research and Education. You'll have more details on this, and we'll make these slides available. And just to give you an idea, the credibility of the organization and what we do on the Hill, just in the past year, we've been contacted by more than 63 different companies and investment firms to get a sense of what is the patient opinion about legislation, about regulation. We've been involved in a lot of clinical trial preps, and we've done about 135 different meetings with government officials on policy and policy formulation that you'll start seeing in the next few months come out publicly. But we're heavily engaged. And then for you folks here, and what you'll hear from our guests, is we seek to activate the patients in all of the policy discussions that are taking place. So that means parachuting patients onto federal panels, in front of legislators, in front of elected leaders across the country, so that you can represent your voice to those who are making decisions about you. But with that, let me go ahead and turn over to Rob, who will talk about the Renal Physicians Association and some of the issues that we're working on collaboratively.
Thank you, sir. Thank you, Paul. Now, Paul, before I get started, maybe we could meet at the break so you could unpack the concept of outhouse talent for me, please. So anyway, thank you for being here. Good morning, everyone. I'm here to talk about RPA and what our legislative priorities are and the ways that we've interacted with AAKP over the years. Oh, here we go. There we go. So who is RPA? We were founded in 1974, recalling that the ESRD benefit was created in 1973. And kind of around socioeconomic issues, we had a group of physicians who figured out that this is a really unique kind of care that's going to be provided to patients with kidney disease, patients on dialysis. How are physicians going to be paid for this? So the group formed, went to CMS, and developed a couple of different payment models, something that was originally called the alternative reimbursement method, which became what is now known as the monthly capitated payment, and that's how physicians get paid for treating patients on dialysis. Now, we pivoted fairly quickly, realizing we had to get involved in quality issues. We developed the first national practice guideline, clinical practice guideline on adequacy of dialysis, and followed that up a couple years ago, or a couple years later, I should say, with the appropriate patient preparation for renal replacement therapy and shared decision-making on initiation and withdrawal from renal replacement therapy. And, so we like to think that we've been kind of in the patient-centric place for a long time, that we've been, trying to figure out ways to make sure that the patient is involved in making decisions about their care. We were an early adopter on CKD issues, and I apologize for the RPA commercial for what it's worth. I would have gotten in trouble with my boss if I hadn't done it. But anyway, early adopter on CKD care issues. We did something about 10 years ago. We did it long enough ago that it's a binder about this thick. It's all electronic now, but it was something called the Identification and Co-Management Toolkit, and this was for primary care physicians and nephrologists to work together to make sure that the patient care was handled in an orderly and an effective way, and it's something that got field tested. There were research papers written about it. It's done very well, and from what I understand, if you use it, it's very successful. It's all about getting the guideline off the shelf and into the hands of people. And currently, we're the only group with a qualified clinical data registry, which is a way to make sure quality outcomes, quality information gets not only disseminated among providers, but also to CMS as well. In terms of the AAKP RPA collaboration over the years, we've had AAKP patient representatives on our clinical practice guideline work groups for years, the ones we talked about on the previous slide. And then we've had patient representatives on our RPA registry work groups on hyperkalemia and CKD metabolic bone disease. And for years, and it has been forever, we've been doing Hill Day together. And I have to say, there is nothing like the patient-physician combination on a Hill visit. It's absolutely the most effective thing you can possibly do. So we treasure our relationship with AAKP. We treasure the participation and the collaboration, and thank you for always being there for us. In terms of our advocacy agenda for this year, I'll go through each one of these, but I'll do it. If you haven't noticed, I talk fast, so I'm going to talk fast through this too, but I'm happy to hang around and answer questions if you'd like me to. Immunosuppressive drug coverage, the living organ donation bill, vascular access preservation, and the community chronic kidney disease bill. With regard to the immunosuppressive drug coverage, there's not a bill yet, but we think there's going to be soon. The goal would be for lifetime coverage. We really have an unprecedented opportunity right now. This administration has been very out front about we want to see this happen this year, and that's unlike has happened in previous administrations. So we really want to strike while the iron's hot. The big news that came out in the springtime is that a couple different shops in the administration deemed this to be a money saver, not a money coster. So that means that all these, I caught myself from using a pejorative there, all these legislators on Capitol Hill are looking to pay for something. They will use this bill to help pay for what they want. So that's a big deal. As soon as it's a saver, you like to think it's going to happen pretty quickly. So Senate and House sponsors are working feverishly to introduce this. We're hoping for a bill in a couple weeks. Maybe get this attached to an extenders package later in the year, but it better happen this year because it's probably going to get a whole lot more complicated next year with the presidential election and all that. I will defer to Zach on all this. Paul's absolutely right. Zach is the shoe leather on the hill here, so maybe he'll have a little bit more insight on this than I do. Our next, there we go, living organ donation bill. It was introduced this February with the new Congress, and this is a bill that's been out there for a few years now, and it's been doing the same thing for a few years. Prohibits the denial of coverage or an increase in insurance premiums for living organ donors. Designates organ donation surgery as a serious health conditions for the purposes of the Family Medical Leave Act, and requires HHS to develop educational materials. Doing pretty well with co-sponsors in the House and Senate. The administration very much goosed this with their executive order that came out in the summertime. We think there's going to be positive news on this, but I guess we have to see. And my understanding is that there's some sort of proposed rule that just got sent over to OMB yesterday that addresses living organ donation, but I just heard about this last night, so I haven't dug into it myself. So this goes back to RPA's kind of socioeconomic roots a little bit. There has been a series of regulations, rulemaking that's happened in the last couple years that has significantly reduced reimbursement for services in the vascular access setting, the outpatient vascular access setting. Not only in what they call the extension of physician's practice. This is when there's a vascular access center that's part of a physician's practice, but also in the ambulatory surgical center. And last year what they did was they proposed to reduce reimbursement for the two highest volume codes by 55 and 54%. And that would kill these vascular access centers, and clearly there were going to be a lot of vascular access centers that were going to close. And if that happens, a lot of time the alternative is the patient has to go to the hospital to get these services rendered by someone who's not necessarily as good at it as the person who's in the vascular access center. So we were fighting to keep the vascular access centers open. It's not an issue that's got a bill per se, but we wanted to raise awareness about this on Capitol Hill. And for what it's worth, about 2 months ago, I guess at this point, we got pretty good news in the 2020 Ambulatory Surgical Center proposed rule, where CMS did not propose the stupid thing that they proposed last year. So we're considering that a victory for now. It's only a proposed rule, so don't want to get too excited about it right now, but we think we've had an interim victory, and we don't think they would try to propose this or try to finalize this when they didn't propose it. That's actually against the law in the Medicare fee schedule, but it's not in some other payment system, so it's not impossible they could do it, but highly, highly unlikely. And then finally, we're in support of a community CKD bill that's out there right now. You can see the bill numbers there. Does a lot of things. Increases access to the Medicare kidney disease education benefit. Requires the GAO to conduct a study on palliative care in kidney disease. Expands kidney care access in underserved areas by adding nephrology health professionals to the National Health Service Corps, and guarantees access to Medigap policies to all ESRD beneficiaries beneficiaries regardless of age. Being perfectly transparent about this is a bill that the dialysis companies have a lot of influence on as well, so there's things in there about a dialysis facility reimbursement. But I will tell you, the whole concept of this bill is not for this bill to get passed per se. These bills will never get passed. What they're actually out there more is kind of a platform for provisions that can get plucked out of the bill and passed as part of something else, and that's happened a few times over the last couple of years. Acute kidney injury coverage in the outpatient setting, ESRD telehealth for home dialysis patients, Medicare Advantage availability for ESRD patients. There's about 3 or 4 things in the past 5 years that have passed that were part of this bill, and because they were part of this bill and had legislative language written and everything, members of Congress could pluck them out and put them in a bigger bill, and that's how they got enacted. So this bill is not really intended to ever get passed. It's intended to act as a platform for important provisions, and we support it for that. So there's my contact information. Please do not follow me on Twitter because it won't be worth your while. But anyway, that's the information, and thank you for your time.
Good morning, everyone. I have a prepared speech, but Ed Hickey said I have to keep this PG, so thank you very much. Oh, I'm sorry. Okay. I can keep it PG. Healthcare in Congress is always very hot. It's really hot right now. There's a whole lot going on, especially in the transplant and dialysis space right now, and Rob did a beautiful job of describing some of those things that are going on. I'm going to start with PG, but provocative statement. Because of AAKP and the community you work with, there is integrity and action in Washington, D.C., and I want to thank you for that. And I bet you didn't think about D.C. and integrity at the same time, or action. So what I'd like to do right now is to talk about kind of the bigger picture so you understand of where Congress and this administration is right now. If you don't understand the ball game, if you will, how do you play the game? So 3 really big overarching themes are happening right now in Congress, and they're not all that novel, but they're a big deal right now. One is reducing drug prices. I know you've heard this, right? It's a lot of talk, and it motivates a lot of what we do as lobbyists, people who work with Congress and with the administration. The second thing is transparency and oversight. Everything these days is about being transparent, industries in particular, and oversight of those industries to make sure that they are being transparent and they're being good stewards of federal programs, especially federal program dollars. The third thing, overarching theme that I want to talk about is this administration in particular, whether you like them or not, you have to give them credit for breaking down barriers and removing roadblocks. How do we work with that? In a lot of the ways that Rob started to talk about, and a lot of ways that I'll get into. So let's start first with reducing drug prices. What's going on in Congress with the reduction of drug prices? Anybody know? There's committee action happening, right? So how does the bill become a law? I know you've seen the cartoon on TV if you're my age. There's 3 committees of relevant jurisdiction is what we call them that have been particularly active on drug pricing conversations. One of them, and they acted first, was the Senate Help Committee. Isn't that cute? Senate Health, Education, Labor, and Pensions. We love our acronyms here in Washington, right? Senate Help Committee. They produced a bill that was bipartisan and strongly supported by all of the committee members, which also means that that bill was kind of the low-hanging fruit. Some of the things that were attainable in the drug pricing space, maybe not the most dramatic things that either the Republicans or the Democrats wanted, but more of the middle ground. And frankly, I think that's where Congress works best. When they're in a bipartisan, bicameral way, they can get things achieved. That's what the Help Committee has in their package of bills, in the law that they're allowed to influence. What do I mean when I say that? The law that they're allowed to influence, those committees of jurisdiction, that term I used, means that their committees are told, these are the laws you can play with. can't touch our laws over here because they're in a different committee. That sounds weird, but it makes sense, right? So the HELP committee is only focused on sections of law, mainly the Public Health Service Act, where they can effectuate change that could help to reduce drug prices. So they've moved on, they've done their work, good stuff. The next committee, the Senate Finance Committee. Senate Finance Committee put together a package that was a little edgy, right? What was so edgy about it? They were talking about negotiating drug prices, the federal government negotiating drug prices with the pharmaceutical companies. When I say edgy, I mean there are a lot of Republicans who don't really love that idea. There are a lot of Democrats who really love that idea, and it's a big sticking point right now. This administration has talked about the IPPI model. Most of you probably don't know what the heck that is. Generally what it is an international pricing index where our country would look to other westernized countries that are quote unquote similar to ours and say that's the model we should follow for keeping drug prices low. Again, not all Republicans love that concept. The administration really likes that concept. Is it going anywhere in this Congress? My bet would be probably not, or it would have to have a permutation on it before drug prices could go down significantly because of an act of Congress. So, Senate Help Committee we talked about, Senate Finance Committee has done its thing. They were less bipartisan, if you will, but they did produce a bill. And then there's the House. I didn't talk about the House. We got the House, we got the Senate. The House has produced a package that is still really under wraps right now through the Energy and Commerce Committee. The Energy and Commerce Committee is led by Speaker Pelosi. She doesn't lead that committee, but she is in the leadership and has handed off the drug pricing bill to that committee and said, work with this. What's going to come out of that could be very different than what's come out of the Senate. Why? Does anybody know? Who runs the Senate? Republicans. Who runs the House? The Democrats. They're going to have very different opinions about drug pricing and what it should look like and what control the government should have over drug companies or not. So we're still in the throes of all this. There's not any great answers right now, but there's a whole lot of discussion that I think a lot of us are hoping will eventually actually lead to reduced drug prices. In all of that, who are the ones putting the drugs in their mouths? You, the patients, or the shots in your arms. Your voice is incredibly important in the drug pricing debate. You've heard a lot about it. You might be bored with it by now. We want to hear your voice, and AAKP is really rising your voice to a much higher level because of the population of ESRD patients, transplant patients who need these drugs for the rest of their lives. So they're being heard loud and clear, and that's important. So drug pricing aside, that was a 10,000, probably 100,000 foot, but I wanted you to understand what's important here in Congress and what we're talking about. The second issue I told you we'd talk about is transparency and oversight. Why does that matter? Transparency and oversight are not just buzzwords. They are real, strongly held Republican and Democratic beliefs. That is the job of the federal government to make sure whatever's happening, especially when our money is being thrown at it, taxpayer money, should be transparent. Every one of you should be able to dial up online and figure out what those insurance companies are doing, what those pharmaceutical companies are doing, what those dialysis providers are doing. It is your right and obligation as an American citizen to keep them honest and to keep them true. I happen to believe that personally, and I think it's a good way to go. So there's a whole lot going on in that space. I just wanted to highlight one thing that I happen to be working on that is kind of bigger than the transplant world. We're insurers. There's a legislation in the House side to hold insurers accountable through transparency. You know the insurers, right? You have a lot of fun with them, right? So do my transplant physicians, is who I represent. The insurance companies, do you know how they use prior authorization? Who knows what prior authorization is? Come on, really? I bet you at least half of this room. Prior authorization, the insurance company says to the doctor, before you give them that service, before you give them that drug, you better call me, the insurance company. Do they have a medical license? No, I didn't say that. Anyway, it's painful, it's frustrating. Sometimes it delays care. Lots of times it delays care. Sometimes that denial of care, that delay of care turns into a denial of care, and it can result in physical harm to a patient because they're not getting the service they need when they need it. So a bunch of us got together, and we are really excited to announce on Monday, don't tell the press yet, but there are 360 patient, physician, nurses, hospital organizations that are supporting this prior authorization cleanup legislation, as I call it. For those of you who are actively working Capitol Hill, HR 3107 is the bill, and it's sponsored 3107 by Del Benning from Washington State, Marshall from Kansas, Kelly from Pennsylvania, and also Barra from California. So take a look at that bill, because I do think it would impact you. And again, it goes to that space of we should be able to check them by looking up and seeing how they use prior authorization. What the bill would do, in short, is require them to report exactly what those delays look like and to which group of patients on which kind of diseases. Wouldn't it be amazing if, when this got instituted into law, we could say, you're not doing it right, right? And those companies, people would then pick the companies who are doing it right. And that, we think, is a good way, a free market way, frankly, to get better insurance companies staying in the market and the bad ones out of Dodge. The last thing I want to talk about is breaking down government barriers and removing roadblocks. So this has kind of been my whole job for, actually, Paul, it's like 30 years, but I have good plastic surgeon, kidding. Breaking down government barriers and removing roadblocks. So what I'm excited about with this administration is that sometimes is they're like, whatever, those are the rules. Let's try something new. Let's try something different. And sometimes that can be very frustrating for somebody who knows the rules and somebody who's played by all of those rules. And it can be frustrating. However, it can also be invigorating to the point of looking at pieces of legislation that have been sat stagnant for far too long. A good example of that, also Rob has mentioned, is the Living Donor Protection Act. The element of the Living Donor Protection Act that has been really problematic for years is the use of the Family Medical Leave Act, right? Can you use Family Medical Leave Act from your employer, which is actually passed through the federal government to you, to donate? Well, duh, of course you should be able to do that, right? Wouldn't that make sense? You're giving the gift of life to someone else, and you can't use the Family Medical Leave Act to do it? It was unclear. And I'm making fun of my own brethren, but the lawyers, if you looked it up online and said, can you use Family Medical Leave Act? I want to donate to my sister, my brother, my friend, whatever. What you saw 2 years ago was a whole bunch of listings in your Google search that said, call a lawyer. Great, really? So we took action, and we worked very closely with a lot of these groups to communicate to the Department of Labor and say, hey, this is why you should do it. And what was kind of cool is I had an associate in my firm, and I said, go find out somewhere in Congress where they said something about this. And she comes back and hands me a silver bullet, and it says, many years ago when the Family Medical Leave Act was passed, there was what they call a colloquy, a discussion between two members of Congress on the House floor, and then one said to the other, hey, we're going to pass this Family Medical Leave Act thing. Can we use that for living donation? I heard that's a kind of cool new thing that's going on. And the answer was absolutely. So what we found in the congressional record was magical. Took that to the Department of Labor, worked with some of our congressional champions. They highlighted it for us as well. And lo and behold, the Department of Labor wrote an opinion that said, ta-da, yes, you can use Family Medical Leave Act to donate. Cool. That's a weird way of making law, right, or making changes, but it happened to work in that instance. And again, a lot of people were surrounding that legal analysis that my firm did to push those efforts in the right place, not the least of whom is Paul. So when you Google today, what do you see? If you ask that same question, you will see the answer is, first, I think, comes up as AAKP, and then probably ASTS, the transplant surgeons, and a bunch of other groups. And the answer is yes. Now go look at the Department of Labor opinion. Those may seem like small victories, but they're huge victories for any of you who have gone through the pain and trouble of finding a living donor, or for yourself or for anybody else in your family. I don't want to underscore the importance of a Google search. It's a public education tool in a lot of ways, right? Otherwise, you have these disincentives to transplant. Well, I looked it up. Doesn't look like my employer's going to help me out, so I can't be a living donor. Whoa, that was happening a year ago, and we're changing that paradigm. So very proud of that, very excited about that, and it matters. Breaking down those barriers, right? It's not like we didn't try for the last couple of years. It was kind of nobody was listening. They didn't have the creativity to think that they could do that. The joy of working with the Department of Labor at this point in time is that they did think they had that power, and they did it. Similarly, immunosuppressant drug coverage, as Rob has mentioned, it's just a frustrating issue. One of the Hill staffers says, I've been working on this for 10 years. It's my white whale. I said, your white whale? Yeah, it's my white whale in the boat and the ocean and everything else. It has been so frustrating for all of us to try to work on an issue where it seems so simplistic. The federal government pays for your kidney that you got transplanted with my taxpayer money, and then after 36 months, they're going to take away the payments for the drugs that you need for the rest of your life. What? That is the dumbest federal policy I've ever heard of. That 36-month limitation on paying for your immunosuppressant drug coverage has got to go. It's got to go away. So what has been the fight? What's the foot drag in all these years? Is it bad lobbying? No, it's definitely not bad lobbying. What's really been happening is the agencies have told us, oh, it's going to be too hard. It'll be a new entitlement program. There's going to be too much work involved. What? So again, what's kind of cool about this new administration, and I know it has its detractors, including me at times, is they're thinking differently and saying, well, wait a minute, it isn't a new entitlement. It's removing a limitation. So everybody at CMS, stop writing a new entitlement, because that's not what we're doing. What we're doing is removing a limitation. So the way we talk about immuno is very important in the context of this administration, and because they are fully behind this with those two important studies we talked about. So there's the appetite, there's the people who are in place, who we meet with on a regular basis at Health and Human Services, at CMS, in other places within the administration, and working with our wonderful champions in Congress, and we have a lot of them, that I think we're this close to getting immunosuppressant drug coverage after many, many years. Boy, will there be a party that day, right? You may see cartwheels from me. It won't be pretty. The last thing I want to talk about breaking down barriers is there was a piece of legislation last year known as the Patients Act. If anybody's been a member of AAKP for more than 6 months, you might have heard of this. This is the bill we didn't like. It wasn't reintroduced. Speaking of cartwheels, right? So that's a huge testament to the work that Paul and Richard and all of you are doing. You made a difference. You had a voice. You said something loud and clear, and you were heard. Where we have to be cautious, and we are very supportive at ASTS and among the transplant and dialysis community of the President's initiative to work on and do a whole lot more in dialysis in the transplant space, is to make sure that what they're saying or what they're doing is matching what they're saying. So, demonstrations are being put together. The first demonstration that's rolled out, we have a little bit of a fear, is going to be pushed towards those big dialysis companies. So did we win in Congress and the dialysis companies are coming back and trying to get an inch over here? We're not gonna let them, right? We're gonna make sure that stakeholders in this universe, and not just big dialysis, is making sure patients are done right by, if you will, in the context of any of these new demonstrations that the administration is handling. I know that Paul is on a soapbox, as he should be, and Richard, in particular Richard, about the patient choice in those demonstrations. The fact that most of these models are voluntary is because of these two guys sitting right here. Voluntary. Who wants mandatory, right? I mean, come on. I want to have choices. Who doesn't want to have choices, especially when it's about your health and your care? So thank you for doing that. We stand behind you, and the transplant physicians I represent stand behind you on that as well. Lastly, I would also, well, I'd like to say how you could get more involved in doing this, and I've peppered my speech with some of that on purpose. Please vote. I mean, here's one thing. It may be a four-letter word to some people, but please vote. Follow the bills. And when I say follow the bills, I mean, don't just look at a little message that you get on Facebook or Twitter or whatever the heck it is, some kind of social media, and go, yeah, I'm just going to support that. You can read them. What's cool is you can go look into the bills, and Paul and AAKP and others put little links where you could go read the bill yourself. And it's really not as complicated as you think. It doesn't always take a lawyer to read a bill. There are also tools we call talking points or one-pagers, and you can get a much fuller perspective on legislation than just being the attack groups that we've talked about earlier. You want to be substantively intelligent about the bills you're supporting or you're opposing, and you can do this. I know you can do this. There's tons of information available online, and if you don't know how to do it, any of us will be happy to tell you more about any of these bills in Congress or demonstrations or action by the agencies. There's tons of information out there. Be informed. I would also say that ASTS is very proud to have some of you have joined us when those transplant surgeons go to Capitol Hill and lobby Congress. Thank you for any of you who've done that. We will be having another, what we call a fly-in on Capitol Hill in the spring, and we're going to ask again, and I hope you say yes, because every time you do, we really appreciate it. And the transplant surgeons are realizing now the power of the fly-in, and we're going to do more of them, and we're going to get bigger in doing that. So we're going to be calling on you more than we ever have before. The other thing I'll tell you is that you don't just have to come to Washington. I know in Washington it's all about us, right? Yeah, look at us, look at us. Your members of Congress, your House members and your Senate members all have district offices. Go there. Knock on the door, pick up the phone, call those district offices. If you go online and you don't even know who your member of Congress is, you can look it up by your zip code, and there's a free website that'll tell you how to do that. You go find out that it's Sally Smith, and there's a phone number. And you call up that phone number and say, I want to talk to Sally Smith about something that's really important to me. And what's important to me is fill in the blank. The bill she hasn't co-sponsored yet, the bill you want her to not co-sponsor, whatever it may be. You can go in district and have those meetings. You don't have to come all the way up here. So there are some ways that you all can get even more engaged in doing what you do so very well. And again, thank you for doing it, and let's keep fighting the good fight.
Good morning. Thank you so much for having me here today. Thank you, Richard, for putting me last. The great thing about going last is you get Rob and Peggy to make some very great points for you. It's really great having such pros always in your corner. Before I get started, I wanted to just take a second and meditate on a couple of things that have been said today. Limitless change, unprecedented change, and unprecedented action. I think that's really the spirit that's in Washington surrounding kidney policy. There's an enormous amount of opportunity. And if there's three things you could take away from, I think, all of our talks, but hopefully specifically mine, think big, build relationships, and be loud. That's how anything and everything gets done in this town. A little bit about the American Society of Nephrology. We're a Big Tent organization, the largest group of kidney health professionals. We have obviously the nephrologists, also everybody from the social transplant care worker, transplant folks, everybody is under this one big tent. We do a lot of the things you're familiar with, the big annual meeting Kidney Week, which I hope to see many of you back in DC for. We publish journals. We give out funding for researchers through our Kidney Cure Foundation. But lately, we've also been taking a little bit of a different approach as well. I think there's some very big challenges or opportunities facing the kidney space. And our organization has tasked us with thinking a little bit differently about them. So we've formed a couple of public-private partnerships, the Kidney Health Initiative, which is with the Food and Drug Administration, NTDS, Nephrologists Transforming Dialysis Safety, that's with the CDC, and then the new kid of the block, Kidney X, which is ASN's partnership with Health and Human Services to accelerate new therapies in kidney diseases. So we do a lot of the typical things, but we're expanding. We're reaching out because there's a big need, there's a lot of gaps to fill. Across the entire Alliance for Kidney Health, we have this decision-making mantra, and I won't read through all of it, but I do want to highlight the first point. And this is exactly the rubric we use to make decisions. Number one, what is best for people with kidney diseases and their families? And then number two, what's best for strengthening the relationship between kidney health professionals and their patients? And then number three, then what's best for the field of nephrology? And I think it's very important that not only us, but everybody kind of keep the same rubric in mind when we're advocating for changes to be made. It's paramount to keep the patient perspective and the patient voice and the patient need first and foremost. So I know you've heard a lot about this in the past couple months, weeks, and today, but I cannot underscore enough how much the Executive Order on Advancing American Kidney Health and the supporting HHS strategy has changed the game. As you're probably familiar, officially there are 3 new federal policies because of the executive order. It's official policy to reduce the risk of kidney failure. It's official policy to improve access to different modalities of treatment. So in-center is important, but also home dialysis and transplant, and hopefully new therapies too, like artificial kidney. Wouldn't that be nice? And then number 3, increase the number of kidneys available for transplant so we can increase the rate of transplantation. So these are now the official goals of the United States government. They have some specific metrics on how they're going to achieve this, and I know you've also heard quite a bit about this, but wanted to especially highlight these, the second 2, ensuring that there are treatment options and choices available to patients, and number 2, really this big, bold goal of doubling the number of kidneys available for transplant by 2030. And I think that's going to be critical in order to ensure the success of this executive order, and really this whole initiative. Looking at this last point, how do we increase kidneys available for transplantation? I know many of you are familiar with the near 100,000 person wait list, but you can see, and this is from the administration's white paper, there's actually a huge gap between the kidneys that are available that were transplanted in 2018, you can see there, and the need. There are about 20,000, give or take, kidney transplants done in 2018, which is a lot shy of the 90,000 people who are on the wait list needing a kidney transplant. So how do we fix this? I don't want to spend too much time on this because I know you're very familiar, but these are some great strategies for increasing living donation. Number 1, let's pass the Living Donor Protection Act. We've been talking about it for years, but I think the administration has really opened the door for us. Let's use this opportunity to just get this one off the board. It's easy, everyone agrees with it. Bing, bang, boom, done. Number 2, expansion of the National Living Donor Assistance Center benefits. So many of you are probably familiar with this program. They currently offer travel support for living donors. My colleague Peggy probably much more deeply familiar with this, but the administration is interested in looking at ways we can expand it. So maybe changing the qualifications to get assistance, maybe paying for things like childcare or reimbursing a certain amount of lost wages. Any way we can remove the barriers for people who are giving living donations. If we're going to expand the benefit, we also need to fund the benefit. They go hand in hand. So we need to increase the amount of funding for the National Living Donor Assistance Center as well. And then this is kind of across transplantation, but I just stuck it here anyways. Let's introduce and let's pass the Comprehensive Immunosuppressive Drug Coverage Act. This has been something we've been talking about as a community for a number of years. I know it's a critically important policy, and it's a common sense policy. So I think, again, with the door open, with the administration really pulling it wide open for us, now's our time to go ahead and pass it. Moving to the deceased donor donation side of this, I think there's a lot we can do to really increase the deceased organs that are available for transplant. So as you can kind of see here on the top of this diagram, there are 145 million people who are currently registered to be an organ donor. But yet last year, there were only 14,000 people who actually received a deceased donor kidney. So somewhere between the start of this process and the end, there is an enormous amount of possible organs and donors that aren't really fully being utilized. And I think there's a lot of changes we can make to help improve this system. So glancing over it briefly, so there's kind of 4 key pieces. There's the donor hospital. This is if there's a deceased donor who's registered or someone who might qualify to be an organ donor, the donor hospital manages it. They notify an organization called the Organ Procurement Organization, or OPO, of potential candidates for donors. The OPO probably does the most amount of work in this whole process of organ management. So they, once they're notified that there's a potential donor, they assess the potential of that donor. They see if they are registered or not. They see look into the medical history of the patient. They notify the Organ Procurement Transplantation Network, which is in charge of matching organs. They're in charge of transporting the organs, and they're also in charge of managing the relationships with the organ donor and the organ donor's family, doing community-based initiatives to really increase people who are registered. So they do an enormous amount of work in this space. Kind of this next tier of the pyramid is the Organ Transplantation Network, and they're really in charge of matching the organs that are donated with possible donors. So that's kind of what we call the allocation side of it. And then finally, there's the transplant center and the transplant surgeons. And so they're the ones who ultimately decide whether an organ is medically suitable for a patient and will perform the surgery. So I think there's a number of interventions we could go into in either of these steps to really improve the accessibility of kidneys. Want to speak briefly about one change to the organ procurement process. This is a bill called the Organ Procurement Optimization Act. It was introduced around the same time as the executive order by Senator Todd Young. And so basically, this bill would create a system where the metrics that are used to evaluate the OPOs are now objective, verifiable, and standardized across all 58 OPOs. OPOs do some great work, but it's hard for a lot of organizations to succeed if you can't actually measure the performance. So I think the administration and Senator Young's bill are both interested in saying how can we kind of tweak it? How can we have the work be shown on the table so that way we can learn from each other and improve access. There's also a parallel RFI, or request for information, through HHS right now that is looking at kind of that same problem, and I think that's going to be due in the next couple of days here. So that's one way to change it. And I think the important thing to highlight, this is actually from a researcher who's looked into this. I think by making this change and by making this process standardized and letting people show our work, we can increase the kidneys that are available for transplant in a low scenario, up to about 1,000 more kidneys per year. In a higher scenario, maybe up to 5,000 more kidneys available for transplant a year. So there's, just by making this one simple change, we can vastly increase the number of transplants that are available. And that's just one piece of the pie. Big problems need big thinking. I think I started off with this. This administration, especially on kidney issues, has been very good about big thinking. This is a snapshot from the executive order. I would definitely encourage you to read it if you haven't already. It's written in plain English, so it's very easy to understand. But wanted to especially highlight this part, removing process inefficiencies and matching and delivery. I think there's so much that can be done in this space to really make this process much more efficient, much more streamlined, and it's going to require some big thinking. It's going to require a lot of us thinking, and we're doing this right now as a community, as an organization. Big problems also need paradigm shifts. Currently, the choice, our system has created a situation where the only choice available for patients is, well, not the only choice, but the status quo of choice available for patients is in-center hemodialysis. And we think there needs to be new solutions and actually enable patients to actually make the choice that they feel is best for their health and their sense of well-being. So I know Adam Bowler spoke yesterday and covered some of the care models that he's planning. Peggy and Rob gave a little bit of an overview, but I think that not only I think the physicians also need to play a very active role in changing this policy and really thinking big, making these big paradigm shifts. The payment models that have been flagged for creating this big paradigm shift. I know we talked a little bit about the voluntary models and also the mandatory ESRD treatment choice model. I think get at this in a very new fashion and a big, bold fashion. ASN and the National Kidney Foundation are actually sending a letter to House and Senate leadership stating as much, like we do think that this model, specifically the treatment choice model, really does constitute this fundamental shift in the business of nephrology, which is incredibly important, and we want to preserve that paradigm shift, that directionality, that big, bold thinking. It doesn't mean that we don't think that there should be changes made along the way. But ultimately, we want to create a situation where patients are able to have a choice, where they're able to refuse having home dialysis or a preemptive transplant if they want, instead of now where the default is they're not often even offered that choice. And finally, big problems need new solutions. I think that it's really incredible that I think the only area of medicine that hasn't substantially changed in 50 years in terms of the choices that are available to patients is the kidney space. There's a lot of reasons for that, and I know you're all very familiar on a personal level and also through your advocacy work. But we need to change the game. We need to actually bring new therapies and new choices to the hands of patients. One way ASN and currently the administration through this executive order seeks to do this is through KidneyX. This is the public-private partnership to accelerate innovation in kidney therapies. It's going big, it's going strong, and we're incredibly grateful to receive the support from the administration on this issue. But we would not be as far as we are without all of you making your voices heard. I don't want to read through this entire graph, but I think that the one thing to highlight, and Peggy did a great job of this, I can sit up there on the Hill and talk all day to legislators and their staff. I can send all of the research studies, I can send all of the graphics. It does not make as much of a difference as you walking in the door and telling your story. That is like the one thing that moves the needle. As Peggy mentioned, it's not only coming to Washington, D.C. to do this. Your legislators all have offices in district or in the state. Often they're hopefully probably like 30 minutes from your house. So contact your local offices, contact your D.C. offices, and start to build that relationship, because it's only through building that relationship that things actually get done. Wanted to specifically highlight the AAKP ambassador, Nicole Jefferson, who's been an incredible ally to the kidney community broadly and also ASN. I was in a meeting with Senator Grassley's office, who many of you know is a conservative Republican from Iowa. His staff told me that they support Kidney X. They support funding putting new money towards Kidney X, which is kind of an incredible thing when you think about it. Like a conservative Republican saying, well, yeah, we want to spend new money. You never hear it. But he said the only reason I care about this issue is because of Nicole. And I think that's an incredible testament not only to her work, but also to the role that every one of you plays in this process. It's only you making your voice heard that makes a difference. And as a society, I am personally invested, and we're very invested in making sure that you have opportunities to do this. I wanted to highlight our upcoming Kidney Community Advocacy Day. This is a list of the organizations who participated last year. Incredibly excited to announce that the Kidney Community Advocacy Day this year will be held on November 6th as part of Kidney Week. So would love to see as many of you out here as possible for that. And it's really a chance for the community to come together under one roof and one banner and one message, and really speak with one unified voice about and raise the profile of kidney diseases. This year, we're still finalizing the messages, but I'm hoping that this is going to be the year that we pass the Comprehensive Immunosuppressive Drug Coverage Act. Hope to be able to use the advocacy that all of our organizations do, and hopefully Kidney Community Advocacy Day, if it's introduced in time, to really draw a lot of attention and get Congress to pass this important protection. And would hope that as many of you as are able can come to DC and be a part of that process. So definitely talk to Aaron if you're interested. I also have my information up here as well. You can shoot me a note anytime. Or follow ASN on Twitter. And I do want to highlight this Twitter part just really briefly. Social media has become an increasingly important part of the work that we do as advocates. Congress pays probably more attention, or a given legislator probably pays more attention to their Twitter mentions than they do their emails, because your Twitter mentions, unlike your emails, are public, and they like to see like good, helpful things on their Twitter feed. So definitely sign up. You can also follow your members on Facebook or Instagram, or a number of choices, and actually follow your legislators, interact with them online. It's very easy. It takes 2 clicks, and you can really make an outsized impact. I know all of our organizations are on social media as well, most especially AAKP. So really your involvement on the social media piece does actually move the needle. So thank you very much. I really appreciate it, and hopefully there's some time for questions.
So we threw a lot of details at you. It's a Saturday morning. You folks are all here. That's a commitment to fellow patients, but most importantly, you have some of the top guns in Washington, D.C. who, 1, have the experience and the commitment, but 2, they're bought into what we go through as patients, and they have put their professions in service to us. So forget the stereotypes that you hear about lobbyists and that type of thing, and think of the expertise that's here on a Saturday morning, who's in the arena every single day fighting the good fight on behalf of us. If you have questions, feel free to ask them. They're very hard to get a hold of because of their activity, but they've given their Saturday morning to us. So we'll go ahead and take some questions here. And then in one of the breakout sessions next, there's a session on social media. We'll drive down into the details of practically what can you do to make an impact. Go right ahead, Dr. Fadum.
Steve Fadum from Houston. Well, I didn't get to make Hill Day because I was teaching at the VA and I couldn't get away to come up to it. So what we did was we brought the Hill to us. We invited Senator Cruz's team, some members of his team, to come to our dialysis unit and make rounds for the patients without us, without doctors or any other people there, one-on-one between the senator's staff and the dialysis patients. And they spent about an hour doing this. They walked around, talked to the patients. They came back into the room and they said, this has been one of the greatest eye-openers for us that we've ever had. And they came away with a totally different perspective of what dialysis was all about and what we were trying to do. This was very easy to do, it was very cheap, but very inexpensive, and very, very effective. I suggest that those of you who have any influence in your communities do this either in your dialysis unit or your transplant center And I think that you will really help the people in Congress, their staffers especially, who really do make a lot of the rules and do have a lot of influence over a senator or congressman to move forward. I really strongly suggest this is a very simple thing to do, and I just can't say enough about it.
Okay. Thanks, Dr. Fadum. I'm going to ask Rob to give one comment on that. Rob, the impact of taking staff through and what staff comes back with when they actually see a patient dialyzing or going through a medical procedure.
It's unbelievably moving. I remember early in my days doing this, we took some staffers to a dialysis unit that used to be behind Union Station, but I don't think it's there anymore. You know, these staffers were coming out, I think it was kind of a field trip for them. They were all kind of lighthearted. Oh, we're going to, leave the office for a few hours type thing. Well, they get to the dialysis unit and a little less lighthearted once they got to the door, but it was a super eye-opening experience for these young people who didn't quite get what ESRD was about, what dialysis was about. So it's an unbelievably effective tool. And Steve's right. You can do it inexpensively. And I can tell you in an election year, if you got 3 doctors sitting around a water table or water cooler, you'll have a legislator show up. So, you extend the invitation, get them there. It can be really, really effective way of doing advocacy.
Next question.
Mary Peterson from the other Washington. We have excellent legislators. We really appreciate their activity, the agency company, and Patty Murray. Okay. Yesterday I tried to address Dr. Newell with a question, and I didn't really think I evidently made myself clear or got a question. I'm hoping Zachary and perhaps Peggy can respond today. You mentioned, I think it was Senate Bill 2063, with which I don't have good information, but in terms of having more kidneys available, it doesn't do any good, from my perspective, to do all these wonderful things that you're doing without addressing the current rule that says that doctors are judged on viability of the transplant afterward, and we lose kidneys that could be used by patients who would be more than willing to accept them, that they're not perfect, but they're going to give them that time until there's something better. How can we address this appropriately? What can we do? What advice do you have? How can we bring something together in this discrepancy that there is?
The physician organizations here and elsewhere have been working very hard with the administration to have conversations about what we call a misalignment of incentives. So I'm very hopeful that something will happen along those lines, and hopefully it will be quickly. It is the crux of the problem, right? And it also goes back to what I was talking about earlier, is if you could what we call vote with your feet. And so if there's the not such a great kidney or die, what do you want? I want the not such a great kidney, right? And the physician's rule in their head is supposed to be to give you the best they can. So it's a misalignment, right? So it's a tough place to be. It's the crux of the problem. So we're on it, we're working on it, and your voices are important in that, but maybe Zach has something else to add.
Just to really underscore that, I think that's exactly right. I was reading that on average, a kidney transplant patient receives or has been passed over 16 times before they're even given the choice of accepting a kidney. How great would it be if, like, every time a patient was given the choice and given full acknowledgement about the risks if the kidney is maybe less suitable, and maybe the doctor isn't held accountable for using that kidney for transplant in that situation. I think. And Paul touched on this a little bit. All decisions are made in this ecosystem, and I think the administration did a great job of kind of like blowing the door off the hinges for making changes. There's now this like big, bold appetite for change that I have never seen, especially in this space. Yeah. But it also requires you to be loud to your legislators online and say we want this change. If legislators and the people at HHS don't hear that this is a change that people want, they're not gonna make it. Right. So be loud about it.
Yeah, I would also say I have to make mention what's in the water in Washington State. You have 3 of the most powerful women in healthcare in Congress, with Patty Murray, Del Bene, and also Herrera Butler are huge champions for all of us, and that's a big deal. So let's make more of them. Yeah.
I'm Paul Holtzeder from Minnesota. Had a question yesterday when Dr. Newell was giving his presentation on the proposed new system for allocating organs. He talked about one provision might be transferring more organs between regions to try to reduce wait times in the longer regions and so forth. I think, Zach, one of your slides showed that when we're trying to maximize the number of organs available for transplant, that minimizing the time that they don't have a blood supply, in other words, the time they're outside of the body, is a key in that. So how do we correlate those two different objectives? How do we balance that if we're talking about transferring more organs between regions, but obviously that increases the time it's without a blood supply?
I think that's an issue for the scientists to figure out. There's people who spend their entire careers looking at doing this. I think there's kind of this immediate change that's been proposed to increase the geographic regions of these organ procurement transplantation networks. I don't know if that's that's going to be like the winning ticket. Maybe we hypothetically would nationalize a system. I don't know, but I want to leave that for the scientists to figure out who've actually been thinking about it. I think it gets to be a very sticky political issue very quickly, and you get people in Iowa saying or Kansas saying we don't want our kidneys going to California. Those West Coast elitists over there, and we want to avoid that because that's not. We want to make sure that the patient, the kidneys go to people who have the need first and foremost, whether that's in Kansas or California or Hawaii.
Yeah, I would just underscore that. So politics at its very base level is the haves and the have-nots, right? And so kidney allocation or liver allocation can be an ugly fight in politics. But what I know is what Secretary Azar said at a hearing recently when asked, hey, wait a minute, you're not going to take my, take my livers or my kidneys from my state and put them to New York City or whatever the member of Congress said. And Alex Azar said, there's a good reason people like me, political people, aren't making those decisions. These are clinical decisions that should be made. So there is a process that Rob can tell you even more about where the clinicians are in a room, and not just the clinicians, but the patient groups are also in that same room deciding the allocation of scarce resources. When it's scarce resources, not everybody's going to win all the time, right? So they're going to be tough decisions. We just know that politicians aren't the ones who should be making them.
And we'll have one more question, just so everybody knows and has full context. We're professionally filming this, so we do simulcast, and we also professionally film it. We edit this, and then we rebroadcast and push that back out on social media so that as many people as possible can see the content today. And sometimes you see variations in the timing of our agenda, but that's what it's about. We have a very talented film crew and production team here that are Washington professionals. They're all in too because they've known folks in their lives that have had kidney disease, and they're really committed to us. So sometimes you'll see alterations in time. That's what it's due to. But hats off to our film team. Thank you. Last question.
I'll use my deepest voice then. I want to put together several different things. Paul, you mentioned employment, employability. Zach, you mentioned ecosystem, and we talked about bringing legislators to meet and hear the stories of the people. Well, there's a broader story, and I think it's our ecosystem, which sometimes we lose sight of. I took one of our congresspeople and laid out for her precisely what kidney disease meant in her community. We're invisible. How many facilities are there? How many people are employed in the kidney industry, as it were? How many caregivers are unable to be fully employed because of the burden of caregiving? And when you lay out the entire enterprise as an economic and social component in a community, it's a different message to legislators. So yes, the emotional impact is important, but also the entire ecosystem of constituents is something we need to tell. Thank you.
You now see a new AAKP geo-targeting expert here, and we will take advantage of him. Rob, one last comment in terms of what he's talking about in terms of the total impact of kidney disease in a congressional district, providers, patients, and the economy of it. What do you think in terms of making that argument to congressional staff about how it impacts their district?
Oh, it's absolutely a essential. You know, I know ASN does a lot of this type of stuff where they go in and say, and the dialysis companies and whoever else, but they'll go in and say, you have 15,000 patients in your state, in your district, wherever. There are 15 units located there, and they employ another 1,000 people or what, you know, I'm just making up numbers. But no, it's incredibly important because they want to get reelected, so they need votes. They want to know who their constituents are, who the players are, who the economic players are in their state. So it's absolutely essential. That is an unbelievably good point that the professionals up here didn't get to, but absolutely important.
With that, our guests will be available for some questions off on the side when we conclude this session. One final point. You heard Peggy talk about vote. You will see this. We'll talk about this more on Sunday. But AAKP is in the midst of the largest voter registration campaign that's ever occurred in the kidney community. We consider every kidney patient a kidney voter, and we're branding folks that way. You should think like that as well. See where folks are on legislation, see where they are in advancing innovation, and think about that when you and your family go and vote and your friends. You have a disproportionate voice and a bigger influence than anyone who can cut a check. You need to have confidence in that, and you need to act on it. We're going to go ahead and break now. You'll see on your agenda that we now go into breakout sessions. Again, I think the session on social media is here in this room, and then you can find the information on your agenda for where the other breakout session is. But again, to our guests, please give a good, generous round of applause. Thank you.